Hello, today we will be presenting a PowerPoint based on a case we were assigned to on our trip to Wiggles Children's Rehab. Our patient presented with developmental delays caused by microcephaly, congenital encephalopathy, and hypotonia. In the next few slides, I, Carolina Dominguez, along with Homer Reyes and Yasmin Rodriguez, will be presenting to you our experience with our patient as well as treatment interventions that could help a child with this condition.
Microcephaly, a condition in which a baby's head is significantly smaller than expected, often due to abnormal brain development. So if you look at this picture, the first baby has a typical head size. The second one has microcephaly, and this is the type of head that we saw with our patient at Wiggles. The third is a baby with severe microcephaly. According to this, there's 2 to 12 cases per 10,000 live births in the U.S.
Congenital encephalopathy, a syndrome of overall brain dysfunction. This syndrome can have many organic and inorganic causes.
Hypotonia, commonly known as floppy baby syndrome, is the patient presents with placidity. It's muscle weakness and throughout the whole body. Hypotonia is not a specific medical disorder, but a potential manifestation of many different diseases and disorders that affect motor nerve control by the brain or muscle strength. Recognizing hypotonia even in early infancy is usually relatively straightforward, but diagnosing the underlying cause can be difficult and often unsuccessful. The long-term effects of hypotonia on a child's development and later life depend primarily on the severity of the muscle weakness and the nature of the cause. Some disorders have a specific treatment, but the principal treatment for most hypotonia of idiopathic or neurological cause is physical therapy, occupational therapy for remediation, and or music therapy.
Developmental delay, a condition of a child being less developed mentally or physically than is normal for his or her age. They're delayed in gross motor skills and fine motor skills, lifting head while in prone, rolling over, supine to sit, remaining seated, balancing, crawling, walking, in speech, and intellectual delay.
The normal 6-year-old child jumps from 12-inch heights, throws with one step forward, catches small ball with one hand.
So our 6-year-old patient can jump from 7-inch heights. She jumps up 1 inch without falling. She catches the ball with both hands in sitting and also can throw the ball but only using both hands while sitting, and falls with running. We were able to witness her running around the clinic during her therapy, and she did fall, and this was due because of the lower extremity weakness. Another surprising thing that we were able to witness was that she could not come to sitting without assistance. She could not hold her head up. It would, drop as we were trying to sit her up. She did need quite a bit of assistance to come to sitting. So our patient is, has some delays in a few areas due to the hypotonia that she presents.
Peabody Developmental Motor Scale, 2nd edition. What we did here was we added the patient's oldest Peabody scale scores for stationary locomotive tests. This is the top table where our patient was evaluated at 59 months, about 2 years of age, and her newest Peabody scale scores. This is the bottom table where she was evaluated at 72 months or 6 years of age. As you can see, our patient is delayed in both stationary and locomotive tests for her age. If you compare both of these tables, you can see some improvement between both of the scales. Hopefully, if the patient continues with physical therapy, she can get stronger and live a more normal lifestyle. We'll go ahead and leave this slide up a little bit longer so y'all can just look at the tables a little bit better.
Patient short-term goals. 1. Child will walk up and down 5 steps without rail assistance. 2. Child will complete 3 seconds of tandem standing in 4 out of 5 trials. 3. Child will jump 1 inch in 4 out of 5 trials without falls in 4 out of 5 trials.
So as we were able to look at the patient's chart, we saw that the patient's long-term goals were for the child will complete floor to stand transfer activities independently 4 out of 5 trials. The child will increase speed from running 45 feet in 10 seconds to under 8 seconds in 4 to 5 trials, and child will walk 4 feet on taped line without heels touching toes in 4 to 5 attempts. We did perform the floor to stand transfer several times. The patient would pick up an object and give it to the assisting PTA, and she did need quite a bit of assistance from the floor to stand transfer, so that is a goal she will hopefully be meeting in the near future. And with running, her speed was actually fairly well. The problem was that she would fall, so that goal looks like it can be met soon if we can help her increase strength in her lower extremities. And for walking on the tape line with heels touching toes, we did not witness our patient perform that, but she was able to walk on tippy toes for about 10 feet, and she was able to perform that very well.
Treatment interventions. We were lucky enough to work with a real patient at Wiggles, and these are some of the interventions that we did with her. We had her standing on her tiptoes with her hands over her head and hold it there for 8 seconds, walking on tiptoes 10 feet, climbing stairs without upper extremity support, a single leg stance and hold it there for 8 seconds, supine to sit without going into prone, she was min assist times 1, and squatting to pick up objects from the floor and coming up to standing, she was max assist times 1. In this slide, we have the pictures of the treatment interventions we did with our patient at Wiggles. So we have a little girl coming up the stairs. She's holding on with one hand, and soon they'll progress to no hands. And then we have a little girl working on her core because our patient couldn't come up by herself or sit up by herself from supine to sit. We have another little girl here standing on tiptoes and holding it there, working with balance and also strengthening her legs. We also have this little boy going up and down doing sit to stands to help those quad muscles.
So for the prognosis, based on the chart, we can infer that the developmental milestone will not grow from baseline. Our patient is slowly improving. The patient will always be delayed in some milestones from what we can see that for the rest of her life.
Evidence-based treatment strategy. So we looked for a peer review, and we found that dancing/movement therapy is really great for the hypotonic child because it develops proper movement patterns, strengthens muscles and bones, alleviate health problems, they get to socialize, and they lead a fuller life. What I really liked about the dancing therapy was if we have a hypotonic child, they need more stimulus around them. So having music, maybe some dance lights, like some of those disco lights, and having them move around and dance is going to help them get stronger. Plus, we're facilitating them to use their muscles by having a fun environment.
Current treatment interventions. Improve postural control and movement. This can be accomplished by using different methods. The first one would be positioning. This promotes symmetry and midline control throughout the body. Therapeutic handling by using different cues such as tactile, vestibular, proprioceptive, visual, and auditory will assist in normalizing postural tone. Increasing extensor tone and strengthening muscles for postural control. Rapid movement using anterior, posterior, horizontal, or angular movement while in prone. For example, having the patient over a ball will facilitate automatic postural extension of the head, trunk, and extremities. Increasing trunk extensor tone and increasing trunk flexor tone. In order to increase trunk extensor tone, we can implement different activities such as weight shifting or spinning. In weight shifting, we could start off the patient in a non-compliant surface doing activities such as sitting to standing, and then can be progressed to a compliant surface, which would enhance visual and vestibular balance reactions along with postural control. In spinning, the rapid acceleration would increase vestibular stimulation and improve posture. Additional treatment strategies. For low-tone patients or who suffer from hypotonicity, it is beneficial to have a more stimulating environment to arouse their central nervous system. No matter what their functional level is, it is critical to teach movement that can be translated to function.
For our reflective statement, we would just like to point out that our experience with being able to observe patients in the pediatric clinic was a great experience and really brought to life the handling techniques and the proper way to approach a pediatric patient. We cannot approach them the same way we would a geriatric patient, or even an adolescent. These children are much younger and they need a different approach to help them be excited about therapy and excited about improvements and meeting goals. Luckily, our patient was compliant and very motivated to participate. We had no problems with her. She was very eager to continue to the next exercise, never said she was tired. Overall excited and motivated. And as everyone else witnessed with their other cases, they did not experience the same. It's hard to communicate with a different child with autism or another developmental delay with communication. It's a lot harder to get them interested in therapy. So our role as PTAs is very important to these children, especially at such a young age. It is important that at an early age we use a proper physical therapy interventions with our patients, and if those interventions aren't working, we do need to alter them to make sure that we're meeting the goals and make sure our patients are make sure we're doing everything we can to help our patients improve due to the impairments their neurological disorder has caused them.
References. These are the two references we used in our PowerPoint presentation. This concludes our presentation. Thank you. We are now ready for any questions.